Good evening, everybody. This is Rana from Digital. We welcome you to our tonight's webinar. We are still waiting for our speaker to join. So in the meantime, I will be pushing some questions as a poll, which would help us know you better in order to respond better to your needs during our webinar.
Hey guys, how are you?
Hey Brandon, you are in direct. Yeah, Rana and Nigel reached 2 times this morning and communicate with you 2 times in order to double check that everything was fine. And right now we fantastic. Yes, just right now we are waiting for him. I hope that he's fine. I hope that he's.
I do as well.
I hope that he's fine.
No answer from him on WhatsApp. No contact. He's not answering. He's not online, so we don't know.
Yeah, we don't know. We don't know because it's quite strange. We tried to reach him via WhatsApp. I did call him, not on WhatsApp, but I did try to call him. So I hope that everything is good from his side.
And if not, Ivan is in the session right now. We could have Ivan do the webinar that he's going to do for the States here in a couple weeks today, literally. So let's just keep that in mind. Okay.
Okay. Plan B. Good.
That's right.
But we are in direct, Brandon. Everyone is listening.
Good.
Good. It's fine.
Good. It's worrying though that that Stuart's not picking up. That's the problem. Yeah.
I'm going to send a quick note to Simon over at Canonberry and just see if he has a way to reach him too.
Okay.
So looking at the results of the poll so far, we have very few answers. So we have physiotherapists, we have few students, we have people with other professions. Some people use gait analysis regularly. Some people know, but they're interested in starting to use it. And some people use it rarely. Most of our users use Android, so more than iOS. And we have 6 people participating, 7, 8, who have Smart already, and some more who do not have, and some more who are interested in knowing more about Smart, our gait analysis solution. And concerning the patient profile, so we have around 40% whose patient profile is mainly sports performance, around 20%, 27% elderly, and around 25% who use it for other reasons. So looking forward to more answers to the polls, so we can tailor our presentation to your needs.
Rana, Stuart's on, looking, but he's not been set up as a presenter. He's just looking at it. He can't talk at the moment. So he's on. Sydney. Right, he can see us.
Okay, I've just invited him to participate. So is he in? Getting ready. So he's in with us, I guess. Yeah.
Okay, I'm going to log off, turn my camera and hopefully the microphone on.
Yeah, come on then.
There's Stuart.
All right, cheers, Nigel. Bye.
So Stuart is finally with us.
Hello, can everyone hear me?
We can.
Yes,
Hi, Stuart.
we can.
Welcome.
Sorry,
we can.
Welcome.
Thanks for the stress.
I know, I was listening to you all talk and I was like, yeah.
Okay.
Okay, so thanks for being here tonight, and I think that the floor is yours now.
Yes. Put the vodka down, Nigel.
Cool. Have you done your questionnaire right now?
Mm-hmm.
And a special thanks to all who are in attendance tonight for this European webinar. We're really looking forward to having Stuart go through the materials again. So looking forward to it. Stuart, over to you. Let's kick this off. Thanks, everybody.
Yeah. Hello, everyone. For those of you who attended in December, I apologize for the difficulties we had with our Wi-Fi. So there will be a little bit of repetition for those of you who heard the first half. Hopefully we've still got you guys, and then we've got some new people as well. So welcome to you all. I always start off these webinars the same way. Essentially, this is it's not me telling you how to do things. This is a sharing of ideas. This is me sharing my experiences with you guys and girls, and it's not a dictatorship. I hope you take snippets from what I say and you bring them into your clinical practice, and if not, then great, and you know, you've got your own ethos. Essentially, I started life, my professional career as a strength and conditioning coach or fitness trainer, and basically I was then recruited by a physiotherapy company and trained up as a sports therapist, and then I did my undergrad in podiatry. So I was quite heavily involved in the musculoskeletal side of podiatry. Pretty much straight away. I didn't go down sort of wound care and diabetic patients and things like that. I specialized more in soft tissue injuries and biomechanics. And then I did a master's degree in lower limb orthopedics and trauma, so I could learn more about the hips and the knees and the relationships. And then I've just finished another master's degree in surgical theory. So I have a nice balance of skill sets that I've looked at over a long period of time. I've been doing this for quite a while, and again, it's just it's a bringing together of ideas. Now, please feel free to ask questions during the presentation. I genuinely don't mind being interrupted. If you want to ask a question, it'd be great if we could have a chat at the end of the session as well. It's always good to get questions, and then we can try and work through these bits and bobs together. Nigel, can we skip forward, please? And again. Next slide, please, Nigel. All right, cool. So the purpose of today, depending on where you are in the world, obviously the COVID-19 pandemic has affected everyone worldwide. I can only speak from our experiences over here. We've had an increase, a huge increase in people exercising, which is great. But we have had quite a lot of people going from doing not a great deal to quite a lot, and that's been a bit of a shock to the system in a lot of cases. We've had an awful lot of patients come into clinic, both in the National Health Service and in private practice, where they've been doing home exercise plans, YouTube plans, which are great, but they have had quite a lot of injuries. So we've seen a lot of Achilles tendons, a lot of plantar fasciitis, and then recently there seems to be an increase in stress fractures. It baffles me how we've managed to come at these different injuries when we've had such a huge pandemic going on, and it's strange how it affects the activity and the exercise lifestyles of people. But the reason I wanted to talk about plantar fasciitis, tarsal tunnel syndrome, is just because they're quite closely linked, and I just wanted to try and give people a little bit of a differential thought process and show you how I've used the PodoSmart technology as well within my clinical practice. The PodoSmart, just before I go into the presentation, I have used now for I bet 3 years, maybe 2-3 years. I don't work for Digital, I just consult and I help out on certain education events, and it has genuinely impacted my practice in a huge way. I work a lot in sport at the elite level as well as recreational level, and I use the PodoSmart running platform quite a lot, especially to return people to running. I also use the walking platform for the vast majority of the time in post-operative rehabilitation. So gait retraining, it's been fundamental for that. So if you've not considered that in your post-operative patient management, I would strongly recommend it because you see really great results with it. Today I'll show you how I used it with this particular pathology and how it's been used for. Nigel? So for everyone who doesn't know, Nigel's controlling the PowerPoint. He has power over all of us. So every time I say Nigel, please don't get confused. I'm just asking him to change slides. Now, essentially, we've got a common site of pain. Insertional plantar fasciitis it must be one of the most common pathologies that presents into a foot and ankle clinic. You could literally make a career on treating plantar fasciitis because there's that many patients. I see roughly 60 patients a week on average, split between National Health Service and private practice, and plantar fasciitis is hugely common. The good thing is when you get a patient coming in who's not responded to treatment and they've been doing the right things, but they're not quite getting there, that's when this sort of skill set comes into play, and we can start really sort of getting down to the complexities and helping these patients get right. Insertional plantar fasciitis, you can get it on the plantar aspects of the foot, definitely, but you do tend to find that it affects the medial calcaneus, right at that insertional point. And you quite often get patients coming in and they're very specific where they point to the issue. So essentially, it's knowing the anatomy around that site. I'm definitely not going to teach anyone to suck eggs on here. You're all professionals, and most of you probably have a better understanding of your anatomy than I do. So we'll go through it, but it's not going to be death by lecture. We want to create an accurate diagnosis. And sometimes it's the process of elimination. If patients have come in and they've been, treated with plantar fasciitis and they're not getting right, have they done everything? Do we know they've done everything in their best possible way? Or is there something else looming underneath, which in certain situations could be tarsal tunnel syndrome or a complexity of other issues? Can the PodoSmart help? Do we have the thought process and the sort of skill set to come up with a differential diagnosis when we're treating these patients as well? That's essentially what we're going to look at now. Nigel? So, tarsal tunnel syndrome, your first observation would be the symptom. When people come in with plantar fasciitis, they often talk about a sharp stabbing pain in the base of the foot, and it affects them first thing in the morning. it's stopping them running, and you often hear patients, you know, it's really impacting their lives and things like that. Tarsal tunnel syndrome is essentially a compressive neuropathy. So the symptoms are slightly different. You've got the nerve itself can get this, it can be referred to as tibial nerve dysfunction or tibial nerve neuralgia. It has a different array of names, but essentially it's associated with the compression of the structure as it courses through the tarsal tunnel. Now, it can be the retinaculum that causes the compression. It can be biomechanics. There are often quite a few anatomical structures around there because you have got quite a narrow space with anatomy coursing through. And then when you throw movement into the equation, and things like burpees that patients are doing at home on these home exercise videos, and you've got squats where they're doing them barefoot, because you do tend to find that a lot of the patients are exercising barefoot in the house and they don't have that support of a shoe. So the feet drop into quite an extensive eversion, and you can physically see the compression of the medial aspect of the foot. Oh, Nigel's sorry. So basically, the retinaculum can get stressed, the tarsal tunnel can get compressed, the biomechanics can contribute to it, and then essentially you've got the activity. The nerve itself, I personally think it's relatively straightforward to go through this process when you're coming up with a diagnosis. Essentially, what you do when you take into consideration the movement that the patients are doing and their activities and the footwear that they're using, it's quite simple. But essentially, when you've got a localized point of pain, the first thing we need to take into consideration is the description of the symptom from the patient. Nigel, can we skip a slide? So the usual suspects around this site: insertional plantar fasciitis, typically, not exclusively, medial calcaneus, sharp stabby pain. You can often provoke it with your thumb. You place the patient into eversion and have a good sort of poke around the medial calcaneus, and the patient will jump out of the skin more often than not. There's also tibialis posterior tendinopathy, or more accurately in these cases, tenosynovitis. The reason I say tenosynovitis is because the description of symptoms with tenosynovitis tend to be more consistent with tarsal tunnel or with sort of chronic insertional plantar fasciitis. And by that, I mean the patients are rating the pain at a good 8 out of 10 on the pain scale. The pain is a little bit more sharp. It's a little bit more, it's affecting them in their sporting activities. You do tend to find that a lot of people, if they've got tendinopathy of that site, they can continue to do sport and activity, and they don't complain. The pain tends to be slightly lower. Now, I'm saying this to you guys, this is anecdotal. This is my experience with these patients. And essentially, whenever I've correlated scanning or imaging with diagnosis over the years, you do tend to find that it's tenosynovitis instead of tendinopathy. Your other sort of more rarer one would be an entrapment of the Baxter's nerve or Baxter's neuropathy. Now, you tend to find that that's slightly more proximal, it's more posterior to the medial calcaneus in terms of where they get the compression there, but it's essentially a compression of the inferior calcaneal nerve. Now, you tend to find that if you've gone through imaging, an accurate diagnosis and treatment, that tends to be a surgical consultation with the senior clinician, senior consultant, I should say, where occasionally you might need the nerve releasing, but it is something that you need to differentially be aware of. Nigel?
Stuart, we cannot hear you. So Stuart is trying to reconnect. Let's just wait a couple of minutes until he's back with us. Stuart, are you there? Your microphone is muted, Stuart. If you hear me, please activate your microphone. Stuart. So while we wait for Stuart, please feel free to share your questions in the chat room, in the chat window, or in the question window. And Stuart, why don't you try to exit and come back? So Stuart is trying to reconnect.
Can everybody hear me?
Yes, we can hear you. Thank you, Stuart.
Okay, I don't know. I'm sorry, I don't know what happened there. It just kicked me off and then I'm back. So I did see in the comments that someone said to speak a bit louder, so I'm going to speak a bit louder. I'm sorry if I sound like I'm shouting. So just to skirt back onto topic, the anatomical pictures that we're talking about now, they're not to state the obvious, are basically showing the correlation of pathology. So I find in my clinical practice that medial calcaneus is the site predominantly for insertional plantar fasciitis, but patients do get it on the plantar aspect of the foot and also distal into the foot. But when you're doing your anatomical assessment, the medial calcaneus is obviously the site where you're going to be prodding around, and often the patient will lead you there as well. Nigel, can we skip? Tibialis posterior tenosynovitis. I love diagnosing this particular issue. I find that it often gets misdiagnosed, and by the time patients get to me in my clinic, they've seen quite a number of practitioners, and I use a variety of different tests for this particular pathology, which I'll go into. But essentially, it's when you get this right, there's a couple of simple solutions for treating the problem, and when you get it right, it can really make a big impact on the patient in a very short period of time. So I do think noting this differentially in your medial ankle, medial heel pain process is very important, because I do see it get misdiagnosed quite a lot. The next one, Nigel. Baxter's neuropathy. So you do tend to find that if you look at the image, I'm not sure how big it's appearing on your computers, but if you look anatomically where the nerve is, you can see that it courses around where you would diagnose plantar fasciitis. Now, I think I've seen maybe one, maybe two of these in the last decade. They've been sort of, again, they've been diagnosed through a process of elimination, where all the evidence-based treatment has been followed, mechanics have been corrected, steroid injections, shockwave therapy, power play treatment, taping, all these things have been used, and the patient's still been in pain, and it's been a case of we need a further opinion on this. And one of them was actually diagnosed with investigative arthroscopy. So the surgeon had a good idea that Baxter's neuropathy was the issue and went in and fixed it, and the patient had a really good outcome. Now, I didn't diagnose that. That was a case of I knew there was something wrong and I wasn't sure what. And it was a shared decision with the surgeon, and we managed to get the patient right, or he did in this case. I usually work on a window of 12 weeks maximum with my patients. When I diagnose a problem, I expect a response, positive or negative, within the first 3 to 6 weeks. And then if I'm not getting people right by 9, 10, 11, 12 weeks, then I start thinking, what else do I need to do here? I don't always leave it 3 months, obviously, for a differential diagnosis, but that's my time frame. I don't tend to go beyond that unless there's like post-operative rehabilitation or something like that. But that's the sort of time frame I will look at when I'm treating a patient. If it starts dragging on beyond that, I'm doing something wrong, essentially. Nigel? So Occam's razor, I think I got to this point last time, and then the PowerPoint crashed. I think it was around here. Occam's razor is a really, really old analogy, and essentially it's something that you should keep in mind. It's essentially the simplest explanation is usually the correct one. So when you get into clinic tomorrow, if you have someone with medial heel pain and pain going into the plantar aspect of the foot, it doesn't mean it's a Baxter's nerve. It's probably the most common explanation, but we want you to be aware of the differential diagnosis and the thought process. So always bear it in mind, simple answer, simple option, usually the right one. And then when you need to get complicated, you can do. Nigel?
Stuart, I have a question for you.
Yeah.
From Ken. Ken McKenzie is asking, are trigger points in abductor hallucis ever a thing in your experience?
Yeah, definitely. Essentially, you've got abductor hallucis can be directly involved with tarsal tunnel. I think when you're talking about trigger point therapy, I would always treat proximal to distal. And I'd always treat the whole, to be honest, whenever I treat patients with foot and ankle pathology, I'll assess them from the waist down. So I'll be looking at muscle imbalances in the hips, in the glutes, in the hamstrings, in the quadriceps, in the calves, and I'll treat all of it. If I find soft tissue tension, trigger points, I'll treat them all, to be perfectly honest with you. I usually spend an hour with my patients, and most of the time when they've got a foot pathology, you'll have tight calf muscles and your ankle range of movement will be restricted. You tend to find that a lot of your patients with similar trigger points to what you're explaining, and also with tarsal tunnel, plantar fasciitis, they will have a very stiff first MTP joint, and when they're in stance, they'll have a very stiff medial column of the foot. So one of the outcome measures that I use when I'm assessing people functionally for, say, for example, for an orthotic assessment is the Hubshop score, or it's also known as the J.A.K.S test. So Hubshop is spelled H-U-B for Bert, H-U-B-S-C-H-E-R, also known as the J.A.K.S test, which is easier to spell. And essentially it's a functional outcome measure of the foot. I find that I use that with every single patient. I find it very useful as part of my clinical process. So with the trigger point development, it's a bit, we have a saying in this country, chicken and the egg. Is it the chicken or is it the egg? Have the trigger points developed that have caused the problem? Most likely they've developed because of mechanical changes in the foot and the knee or the hip, and there's been a knock-on effect further down the foot. So never just treat the pathology in isolation, definitely treat the entire sort of process. And I think trigger point theory and soft tissue work in my practice is essential. I think if you are a podiatrist in this seminar and you don't do soft tissue work, learn to do it, or develop a relationship with a therapist that does do it, because it's essential. You definitely don't just change the mechanics of someone's foot with orthotics or insoles in this respect, and don't address the muscle imbalances and the soft tissue adhesions that you get more proximal in the body or around the site. I hope that makes sense. Obviously, telling the podiatrists in this group to go away and study, I'm not trying to take work off the sports therapists that we've got here, but try and work together as a team, and it is an essential part of your practice. I hope that answers your question.
Stu, I have another question for you.
Yep.
It's from Wendy. Wendy says, would you leave a bit longer before looking for a differential diagnosis to PF if patient is older?
It's a good question. You have to sort of look at patient compliance. In terms of the elderly, yeah, I mean, you've got, I'd say 3 months as a maximum is probably a decent amount of time. If you've got, let's say, for example, you record your pain score on the first session as 8 out of 10, and you've got an elderly patient with complications, he or she might have had a hip replacement, or they've got arthritis, so the gait's affected anyway. Then you have this foot problem, which causes other issues in itself. If they rate their pain as 8 out of 10 on week 1, and it's still 8 out of 10 at week 12, and there's been no difference whatsoever, you need to be thinking differentially by that stage. I tend to see patients first session and then 6 weeks later. That's just the way I do things. If I'm treating someone with, say, shockwave therapy, or I'm a bit more proactive in their rehab, like I'm doing soft tissue work, then I'll see them more regular, obviously. But I think 12 weeks has got to be a thought process, or a time check for yourself, regardless of age. You should see a response. You might not see a cure, but you should see a response in that time frame, at least something positive or negative. I hope that makes sense, Wendy. Are we okay for questions, Raina? Do you want me to carry on, or I'll carry on? So, tarsal tunnel. We've all dealt with plantar fasciitis, but more often than not, the tarsal tunnel will get missed. sharp, burning pain for your plantar fasciitis, neural pain, compressive neuropathy, pins and needles, other descriptions like this for your tarsal tunnel. So when they come in and describe the symptoms, ask yourself, are they describing this the right way? And are they making sense? In which case, start, you know, put your thinking cap on and start thinking about what you're going to do. Now, there are different tests for this pathology. I've only included one in this presentation, so not to confuse things, but there are two other tests that are very common. The first one that I haven't mentioned is the Tinnel Sign. Tinnel Sign in this country, it's also called the Percussion Test, where essentially you're tapping on the nerve with two fingers. You can tap anterior to the medial malleoli or posterior to the medial malleoli, depending on which aspect you're trying to look at. The Tinnel Sign is probably the most, in this country definitely, it's definitely one of the most common tests that we teach at university. I think the physiotherapists that may be on the seminar, or the sports therapists, will probably have come across the triple compression test, which I'm going to come on to in a minute. You've probably all used the Tinnel Sign. Tinnel Sign's very useful, but I've just found, just anecdotally, again with my own experiences, I've found that the triple compression test is slightly more specific. But don't get me wrong, I will use all the tests anyway. For the amount of time that they take to use, I'm definitely not saying one test is better than the other. I'm just saying that my preferred option would be the triple compression test. Now, what I have done, I've put some links to the YouTube videos on the slides, and also I can email you. Well, we'll get one of the guys to email through the other two tests with YouTube links on them as well. I tend to use a channel on YouTube called Physio Tutors when I'm educating patients. The reason for this, the Physio Tutors website, I don't have an affiliation with these guys. They just do really good work. Their channel goes through evidence-based application of tests and treatment plans, and it's very clear. It's very clear and it's very up to date, and it's a great tool to use with your patients. The video link that I'm going to send to you guys for the triple compression test is their version of the tutorial. Obviously, I can't show you when I'm in first of all, when I'm in Manchester, and second of all on the webcam, so I can't go through it with you. But the test is very clear. It's only a couple of minutes, the video, and it's very good to look at. But again, I found that the triple compression test more specific. I've had patients in where I've done Tinnel Sign, and I've also done a test called dorsiflexion eversion test, where it does what it says on, it basically says in the name. You basically dorsiflex the foot, maximum eversion, and then you just palpate around the medial ankle, around where the nerve courses, and you're looking for pain. You do this with the patient lying on the side, so you've got access to the foot. But I do tend to find that that test causes pain no matter what the actual problem is. I've not found it completely specific. I will still use it just to get a feel for the patient, but I've not found it specific enough in clinical testing. You might do, it's just I haven't. So I tend to skirt back to this triple compression test, which I'm very comfortable with. You've also got things like, with the plantar fasciitis, the palpation around the sites as well can be sometimes a little bit confusing. But with the triple compression test, it's a certain 3-part movement, and you're allowing a time frame as well. You're basically placing the foot into a position, palpating the site, and waiting a period of time, 10, 20 seconds for the foot to go off, and it's very specific. So I encourage you to watch the YouTube link on that, please. We will send you the tests out and you can look for yourselves, but the Physio Tutors platform, very good. Now,
Stuart, I have a question for you.
Yeah.
Okay, it's from Kenzani. And the question is as follows: if you are waiting 12 weeks to see if the differential diagnosis is effective or not, would that be altered as patients tend to develop various compensation strategies as treatment progresses?
Yeah, so please don't take the 12 weeks as literal. The compensatory pathology is a huge part of a podiatrist or sports therapist or physios clinical consideration. When I say 12 weeks, I just mean I expect to see a resolution by 12 weeks or at least progression. If I'm reviewing patients, depending on how much pain they're in, I'll review them sooner. And I'll often think about differential diagnosis sooner. I'll also have an open communication with the patient as well. So are things going okay? Yes, great. Okay, keep going. Or if they're still struggling, I will get them in sooner. The last thing you want to do, and anyone who works in biomechanics will tell you this, is the last thing you want is for the patient to develop an antalgic gait. We don't want them walking away from pain and creating problems elsewhere. Definitely not. So the 12 weeks, I definitely don't want to confuse people. The 12 weeks is my sort of maximum. It's more than enough time to develop compensatory problems within that time frame. You can develop compensation within a few days, to be perfectly honest with you, if you're limping. And often when patients come in to me, they're usually chronic. They've had this problem for a long time. Most people that I'm seeing at the minute started with the problem in the UK's first lockdown, which was last year, when they started exercising. This is just the current climate. So depending on your country and how your patients are presenting with different things, you're definitely managing the time frame differently for yourselves. So you're absolutely right. Compensation is a real consideration. It's usually something that's picked up in that first session. But it's definitely, I'm definitely not saying to you the patient will be all right and I'll leave them for 12 weeks. It just depends on the situation. I hope that makes sense. Nigel, can we skip? So in terms of cricket as a sport, I don't work a lot with cricket. And when this one came to me, I genuinely have no idea how he managed to injure his foot in this way. I don't know how popular cricket is in Europe. It's very popular in England, Australia, and a few other places, South Africa. I know it's very popular. But with this, you have, if you look at the figure in front of you, you've got quite a lot of padding around the leg and the ankle. This guy has managed to injure himself while he was batting. So those of you who are not aware of cricket, you basically got a very hard ball being thrown at you very quickly, and your idea is to hit it as far as possible. The ball managed to impact the medial aspect of his foot. No idea how. But essentially, if we just skip forward for me, Nigel. So this is the case today. Male patient, 35 years old, professional athlete, been a professional cricketer a long time. His injury history was very unremarkable. He's had a couple of hamstring problems, nothing major, sometimes an occasional stiff back. There was no remarkable injuries for this guy. He's been playing professional cricket for, I think, 15 years or something like that. So his injury history for a professional athlete was pretty clear. It wasn't too complicated. He suffered trauma from the ball hitting the foot during training. So it was during batting practice. So he's basically got people throwing a ball at him in rapid succession at fairly high speed. And the ball somehow bounced under the pad and hit the inside of his foot. So it was an impact injury in this respect. In terms of someone's just put on the chat there that it does more commonly occur in bowlers, it absolutely does. This one is a trauma, so it's slightly different, and it sort of threw a little spanner in the works. So he had an X-ray, obviously, because he's been hitting the foot with a very hard ball, and he was placed in an air cast boot to stabilise the foot for a couple of weeks. He had an X-ray immediately after the trauma, and then 2 follow-up X-rays as well, and both of them ruled out fracture. Essentially, the boot stabilised his foot or immobilised his foot, and then once we removed the boot, a couple of weeks later, it wasn't me that removed it, it was the physiotherapist at the club. He started with this numbness and this tingling going down into the foot, and it was affecting him distally and medially. Now, I mentioned his mechanical lower back pain and his hamstrings. Whenever you've got neural pain in a foot or distal nerve pain, you always should realistically consider the lower back. I think there's a common sense approach. You tend to find that if there's lower back problems, not in every case, but you do tend to find bilateral symptoms. If you're unsure, definitely consider speaking to one of your physiotherapy colleagues or a sports therapist, someone who can assess the back a little bit more comprehensively. In my situation here, I was very lucky. I was working with a high-level physiotherapist who cleared the lower back, so there was no major issues with that. No disc pathology, just mechanical symptoms. Following the removal of the boot, he was sent for an MRI scan, which confirmed soft tissue edema around the site of the trauma. The ankle was still bruised after 2 weeks, actually. A nice big round bruise on the inside of his heel. There was mild swelling, and there was tenosynovitis noted to the posterior tibial tendon. So he got the tibialis posterior tenosynovitis from the trauma. The interesting thing with this case, and it's why I've brought it up, is because A, it wasn't a mechanical injury, it was trauma. B, he did have posterior tibialis tenosynovitis, but the interesting thing was we treated that. The consultant, the sports medicine consultant, and the radiologist did an ultrasound guided steroid injection into the tendon sheath to switch off the tenosynovitis. And we did have some improvement in symptoms, but the tingling and the numbness did not resolve. He still had that. And this was not for him, but it was a really good case to sort of be involved in, because you've potentially got 3 things all going on at once. And when you talk about compensation, there's a conversation to have with yourself here, because potentially has compensation created the issue in the plantar aspect of the foot, or has the trauma just created the inflammation that's blocked everything, and then there's been a multitude of symptoms. But it was very interesting to see how this unfolded. Nigel, can we just skip? So as part of the process, this is where your PodoSmart technology comes into place. Now, I'm going to go into treatment in a minute, but essentially what we did was, when he first came, excuse me, when he first came out of the boot, we obviously then started thinking differentially. Now, because this guy is a professional athlete and he's an international player as well, there's obviously people involved. So we had a sports medicine consultant, a radiologist, a physiotherapist, and myself. And we were all discussing this case around the table. Now, the first idea was to get this guy and check how he's walking following the trauma. The great thing about your question earlier on about compensation, one thing I've used the PodoSmart for to a very, very effective level is gait retraining. Following a trauma or an injury, most patients will overload one side, they won't put enough power through the other side, and there'll be an all array of compensations going through. Now, with this chap, what you do tend to find, that patients, when they've got tarsal tunnel syndrome, they do confirm that they often get it at toe off or propulsion. So when you're propelling forward off your step, you can feel the symptoms. Now, that's not always the case, but if you look at your data that you've got in front of you, I've pulled together his initial walking analysis. His cadence, or his steps per minute, 66, speed 1.8. Not overly important data. You know, he's just walking a bit slow and he's injured. His symmetry was 86%. Now, knowing the pathology and what we've got going on, there was a reluctance to walk off the big toe joint. He was compensating in that respect. What we needed to do, or what I needed to do with the physio, is we needed to address the mechanics, get him back walking, as well as treat the actual problem, which you know is easier said than done when someone's had a trauma like this. But that was the initial assessment, and the initial assessment was just to get some data in front of us. So now we've got information we can look at, and we can look at this weekly. Nigel, can we just skip a slide? Now, the treatment plan that we sort of adapted for this patient, he had a low gear eversion posture. Now, depending on where you are in the world, you could say this is a more flattish foot. It's some people say you pronate. I don't like that word, but some people say you pronate. But he had a flat foot posture. Now, the main thing with this is I don't over-prescribe orthotics too much. If someone comes in with a problem that's related to a flat foot posture, then I will deal with it. But in this case, this was a trauma of a professional athlete that's been doing very well for himself. Do I want to start changing the mechanics based on his observations? Probably not. However, insole devices, orthotic devices can be used as a short-term measure to refine the individual whilst the physiotherapy and the treatment plan takes precedence. So it's a small part of a big treatment plan. Now, his Hubshop score, which I was talking about earlier, or his JAX test, was 1 out of 3, and he had a moderate to high force for supination resistance test. Now, these are two things that I use to see in a patient standing, how the foot function looks and how their force looks when they're standing naturally. Now, he was very loaded through the medial part of his foot, which is obviously, when you look at the literature for treating any of the problems that we've discussed in this presentation, refining the medial column is sometimes something that we would look at. Now, in this case, I gave him a very simple medial wedge orthotic, which immediately improved his functional foot scores. He also had soft tissue mobilization and manipulation of his medial column to free the whole process up. And he was having soft tissue work done on his calves, his hamstrings, and keeping himself nice and loose. Now, I gave him an insole device to improve his foot function. Ankle dorsiflexion, as you can imagine, coming out of a boot, massively restricted. So he was having a good kicking, a good pasting, and lots of elbows with the physiotherapists who were making him cry, which was fun to watch. And essentially, that was reducing some of the soft tissue. Now, his right foot on clinical observation was more abducted. So it was more externally rotated than the left foot, and there was more of a valgum noted in his knee when he was walking. So we had more compensations coming in further up the kinetic chain, which is why we have to look at the whole body and not just the foot and ankle, especially for podiatrists, because sometimes podiatrists ourselves, we lack a bit of confidence in looking further up the body, but you do need to do this, and if you're not confident, work with someone. But what I did at this point was there was a reluctance to load the foot, as we saw in the previous data collection. Sorry, Nigel, can you just go up one, please? Up a slide. Yeah, perfect. So the right foot, he wasn't loading at propulsion, and obviously the two main things is the lack of propulsion and the 86% symmetry. Nigel, if you could just go down one, please. So what I did was I gave him gait retraining. Now I found using gait retraining in conjunction with PodoSmart a phenomenal tool in treating patients with any pathology and any sort of situation where you've got post-op back pain, knee pain, hip pain. I've found the gait retraining fundamental. I recently wrote a thesis, and one of the things it was looking at was post-operative rehabilitation, where there was very little gait retraining carried out. So patients are just expected to learn how to walk again, and in my experience, they don't. They continue to struggle. Now, the way I do it with the gait retraining is I will collect the data. So with the PodoSmart, we had a cadence of, I think, was it 66? Nigel, sorry, can you just go up one? His original cadence. Yeah, 66. Thank you, Nigel. Sorry, if you can go down one. So his original cadence was 66. Now, the thought process here, and I hope this makes sense, is he's taking 66 steps per minute. But I know there's a reluctance in loading the right foot. So we used a metronome, which is a popular tool in music. For those of you who don't know, it's just a noise. It's a and essentially what we do is, or what I do is I give the patient, so his cadence was 66. I gave him a metronome, which he downloaded on his phone for free. And we set the cadence at 70 and then increased it to 76, I think. So he was taking, and we had him just doing walking daily. I think it was a 15-minute, 20-minute walk daily to start with. Now, because he's walking with a metronome in, he has to hit the floor on the beat. Now, by doing this, he spreads tissue stress equally across the two limbs, and he forces himself to load that injured foot, which we needed him to do at this stage. You do 4 weeks of this. I think we did 6 weeks, and then we did another collection of data. And the gait retraining in conjunction with the physio, the orthotics, the deep tissue, myofascial release work, and then his day-to-day management, which involved power play use, which is a compression ice machine, which is a phenomenal tool for reducing inflammation. There's other versions like the Game Ready. Simply just soaking your feet in, freezing cold water can work as well. But he was doing that every day. He had a tibialis posterior treatment plan and nerve flossing exercises. So we gave him stretching of the medial aspects of the foot and some strengthening work, and then we were basically flossing the nerve from the whole way down. So from the stretching the nerve off from the sciatic point all the way down the foot. So they were working really hard with him. He was also having things like acupuncture and some other physiotherapy incentives. So then when we fast forward on, Nigel, if you can skip us down. This was at, was it 6 weeks? I think this was at 6 weeks. It might have been slightly longer, it might have been 7. We've now got an improvement. So what you've got here is, and this is the crucial part of any sort of technology that you use in clinical practice. This is for the patient. You can diagnose a patient and you know what's going on with the patient from your clinical experiences. But what this does, this shows the patient the progress they've made and where they're going. And it's fundamental patient education. We can tell people all we want. When you can show them, it makes a huge difference. Now, when he saw his previous scores, he's now got 98% symmetry. He's now loading and propelling healthily off the distal part of the first MTP joint, and he's walking more efficiently. His pain levels reduced as well, and everything was a positive outcome. It all started to fall into place quite nicely. But that was just essentially using the gait retraining as a a learning tool as well as soft tissue work. Now, what you've got to bear in mind as well, the insole device that I gave, I think he still uses them in his when he's doing his weight training. So he still uses them in his gym sessions because he feels a bit more supported when he's doing squatting and deadlifting. So he's still using them. I don't think he's using them for cricket, but he's definitely still using the insoles for soft conditioning work. Excuse me. But what you've got to bear in mind with this data collection, this is all him. When I've asked him to walk again, he's only got the Digisol insole and he's not got a corrective device in there as well. So this is now a learned behavior, and this is how we've managed to change his rehabilitation. So granted, we did have a complication. We did have tarsal tunnel syndrome. He was positive on, in this case, both Tinnel Sign and triple compression test. There was potentially mechanical contributions to it, although that wasn't the cause. It was trauma. It was a big heavy ball that hit him in the foot, bizarrely. And you can see how the process could quite easily have carried on if we hadn't have got a grip of it fairly early on. But in this situation, you had two problems, both at this, well, three technically, if you count the soft tissue work as this trauma as well. So it was a really good case. If we just go down one, Nigel, I think I'll put one more slide in. I'm really sorry, guys, but from mine, I can't properly see my my progressions here. But when you're using the Podo Smart, when you do the walk analysis, there's an evolution tab that you've got when you do the walking analysis, and that is an absolutely brilliant tool for patients. It's one of the ones that I've used hugely in post-operative rehab. The main reason being is because a lot of the post-op rehab is walking. You know, it's not running essentially. So we have the evolution tab, and we can show the patients again the importance of the education and showing them how they're responding. So if you've not used the evolution tab and you've not been using gait retraining, I encourage you to use them. They're such good tools. They're not detrimental. They're not really expecting you to step out of your comfort zone too much, but you're taking an active involvement in retraining a patient. More often than not, when I have patients coming in, whether it's a walk or a run, I often find that people are given treatment plans based on time parameters. So start with a 10-minute run and then build up to 15 minutes and then 20 minutes. And you're not really changing anything. At least with control and metronome work, you are controlling the variables. And I've seen, especially in the last 2 years, patients recovering a lot quicker because we've got this active role. And I hope that makes sense. Excuse me. Nigel, can we skip? Oh, questions. That's it. I really hope that I'm still live and you can all still hear me. It's not broken again, but has anybody got any questions?
There's a question from Emmanuel, and he's asking, the gate lines seem to be off the green corridor. How do you take that into consideration or not? And where the orthotics were based to?
I'm not quite sure of the question. I'm really sorry. Could you just where did they get the orthotics from? Did you say?
No, the second question was where the orthotics were based to. Where were they put?
Oh, as in, so it was a simple 4-degree medial wedge device. Essentially, it was an EVA, medium density EVA. 3/4 device. There was no leg length difference. There was no additional complications. It was just a very simple medial arch support that improved his functional foot scores. And I tell people all the time, and I've had arguments with people about this in the past. If you're going to give an insole out, it has to change something for the positive. So I use the outcome measures like the Hubshop Score to show the patient that it works. If I can't justify an insole being used and working, it's not doing anything. It's just an expensive piece of material in your shoe that you're going to end up throwing away. So I always encourage people to use outcome measures when they're prescribing the devices. And in this case, it was a very simple device. I think it was the cheapest one that we do, which was about €55. It wasn't expensive, but it worked for this patient.
Okay, there are some more questions. So Siri is asking, can you describe nerve flossing exercise? And then Sarah said, what nerve flossing technique would you advise?
So the nerve flossing exercises were essentially dynamic stretches of the nerve in position. So like the one of the ones that we went through with them, and it was predominantly the physiotherapist that was doing the nerve work, not me in this respect. But like a really good one that we got some really great results out of was essentially just a straight leg raise. So the patient's lying flat on the back. What I will do is I'll send Raina some video links of the stretches that we used in this respect, because that will be easier for you than me trying to describe them on the webcam. But essentially, we always worked proximal to distal, so we've freed up the sciatic nerve initially. And that was I have to admit that was led by the physiotherapist, but essentially we freed up the sciatic nerve with straight leg raising, resisted dorsiflexion, plantarflexion, one leg up in the air, one leg down, freeing up the nerve. It's a great exercise. It's similar to I suppose it's similar to a slump test, but a bit more active. We also did stretching we did active mobilization of the fibula head at the point of the knee to free up that aspect. You tend to find that the peroneal nerve can get a little bit compressed around that site. So it was a case of stretching off the nerve all the way down the leg. And then obviously we were doing active work at the foot and ankle using therabands and stretching the nerve through there. But I'm really sorry, it's a pathetic attempt at explaining it, but I will send you some video links on the exercises. We'll do a little mail out along with the tests, make life a lot easier for you. I hope that makes sense.
Okay, we have a question from Annette. She's saying, do you ever use the PodoSmart insoles on top of the insoles you have made to see the effect of the insoles?
No, essentially the footwear, this is probably a question for Digital to be fair, but the footwear, if you're in a shoe, the footwear doesn't affect the Digital outcome. So if you're in different types of trainers, like for example, Hoka, if you're in a Hoka shoe, or if you're in like a free running shoe, to the best of my knowledge, it doesn't impact the data that you get from the Digital insole. I definitely wouldn't put it over an insole device, because I think you're just going to skew your data, especially considering how long you're actually going to be testing them for. If it's a walk, it's 1 minute. Run 2 minutes. It's not a long time to walk without their prescribed insoles in. So I would never. I'd never place the insoles in the shoes at the same time. No.
In fact, I would also like to say that we're working on a new product that would be able to incorporate our sensors into orthotics. So soon we will be having this possibility. There's another question from Alexia. Is the PodoSmart useful for running shoe prescription? In other words, to assist the patient choose the right shoe? Well, yes, because in fact, if we use the PodoSmart insoles in different shoes, we can see if this implicates the walk or not, implicates the run or not. We have done some comparison for patients using different shoes, and we see that there is an effect.
I've been working quite heavily in the running world, especially in the last 12 months. I have a lady who ran a personal best at the Olympics. She did phenomenally well, but I was lucky enough to treat the lady who owns a running shop locally, a very successful running shop. And I treated her, and she used the Podo Smart, and now I'm going in and helping the team and training the team up, and everybody saw the benefits of it. And I do think the Podo Smart, along with your sort of clinical assessment as well, I advise patients on a daily basis what footwear to look at based on my observations. So yeah, I think it's a very, very useful tool with running in particular.
We have a question from Peter saying, what does mean the orange color on the hip muscles in the PodoSmart data analysis of the cricket player?
That's a very good question. Essentially, we were Nigel, can we go up, please? I think it's 3 slides. One more. Now I can't see this on my screen, but I think one of them was Rainer. Can you read the figure on the left? Is it 28?
There's 26 on the left and 41 on the right.
Right. So essentially, what we were looking at is you're looking at more of an equal distribution through your gluteals and through your hip flexors and through your calf muscles as well. Essentially, he was because he was walking with an abducted right foot because of the pain and other bits and bobs that he had going on. He had quite a lot of his SI joint, his sacroiliac joint on the right hand side was very tight. His glute med on the right hand side was tendinopathic, so he had glute med tendinopathy as well, which was another compensation. It's definitely something you immediately want to look at and start treating, because your glute med stabilizes you when you're on one leg. It's very common that becomes the dominant muscle in the gluteals over the glute max when someone's had an injury. So I use something called a posterior chain test, and that's an important test. So essentially, he was overloading the right hand side at 41%. Nigel, can we go down to the comparative analysis? Just two, I think it's 2 slides down. And then what? Oh, sorry, go up one, Nigel. Rainer, could you read those figures to me, please?
So here we have, if I read correctly, 10% on the left and 15% on the right. Yeah,
so we had a fairly drastic reduction in muscle overload, in particular on the right hand side. They're always going to be a little bit elevated because this was at 6 weeks as well. So this was a massive progress as well, because essentially it showed more symmetry in the muscle firing patterns in the posterior chain, in particular in this case. Like I say, his lower back was stiffening up mainly because of this boot that he had on. And that's essentially what you're looking at. Whenever you're looking at your figures on here, the main thing that you should be considering is symmetry. You want both legs doing roughly the same amount of work and at the same efficiency, and you want to spread that muscle load and that tissue stress equal. I hope that answers your question.
We have a question from Jan O, and it says, do you retrain gait with other stim than cadets?
Do I train gait with other methods other than what I use? Is that
perhaps he says other stim than cadets?
Oh, other stimulus. I think this is what you mean. I'll be honest with you, the main method I use is the metronome, because ultimately the reason why I do that is because A, it's free for the patient, and B, it's a control for them when I'm not there. I can't be with them when they're doing the gait exercises all the time. So I gave them this just to sort of be doing, and that's the main one that I use. I have done treadmill-based gait retraining in the past. there is some use in that. There was a concert a few years ago, a very tragic event in Manchester at the Ariana Grande concert, where there was a bomb blast and a lot of people tragically died. I worked with the bomb blast victims, and we used different methods of gait retraining following that level of trauma. And I used an Alter G treadmill, which is a gravity-based treadmill, and I used a normal treadmill, water walking. So there was different things that we used in that respect. But for day-to-day use of gait retraining, I mainly use the metronome. I really hope that answers your question. I wasn't quite sure what you were asking there. Sorry.
We have one more question from Miranda saying, any tips on how to view the data analysis side by side, pre and post exercise plan, please?
Well, essentially, you're doing it in your initial clinical assessment. So you'll look at, I use a modified sphigometer test, so a blood pressure cuff. I use a modified sphigometer test to check strength on different muscles. I use a posterior chain activation test as well to check the firing patterns in the posterior chain. And then we start looking at symmetry and gait and things like that. So essentially what you will do in your initial assessment is you will collect your muscle imbalances and your data and your strength, size, things like this. And you'll do your initial gait data collection. Essentially then it's a case of retesting. So I'll do the gait analysis and go through it like I've shown you. And then I will recheck my muscle firing patterns and my strength and do it as a comparative. That's essentially how I do it. If you Google modified sphigometer testing, so blood pressure cuff, you will find lots of literature on the internet about that. It's a very old test and it's very subjective, but it's very useful, especially when you've not got a strength lab. Like a lot of the professional guys will have isokinetic testing, which gives you a digital readout of strength. But everyday patients don't have access to this, so that's where the blood pressure cuff comes in very useful.
So we have Harriet who's typing. I don't know if she's gonna ask a question, but so far I've passed everybody's questions. So while Miranda is typing, so I just wanna thank you everybody for attending this webinar today. Please take a couple of minutes or even less to answer our evaluation form. I've posted the link, and if you are interested in having an attendance certificate, please send me an email and I will, including your full name, and I will be preparing the certificate and sending it over to you. So Miranda saying, thank you, but also how do we physically get the comparisons on screen? So here I would like to say that also we have the evolution option. So maybe Stuart would talk a little bit more about this.
Yeah, so essentially with your strength scores and your exercise plan, you obviously can't visualize that aspect of the data in this situation, like I say, in the absence of isokinetic testing. But with your PodoSmart, it's very straightforward. When you do an immediate gait analysis, whether it's walking or running, on your patient profile database, you will have it in front of you and you'll have the dates of the analysis right next to one another. In terms of putting them up on the same screen side by side, I don't think you can do that. You just have to click on the two tabs and go through them separately. In certain situations, you could print off the two and put them on your screen side by side. But it's a fairly straightforward process when you're just going through it tab by tab. But in terms of putting them side by side on the screen in front of you, that's a Digital question.
Okay, so apparently, since there are no more questions, I would like to thank everybody for attending. And I would repeat, please don't hesitate to send me an email if you'd like to have an attendance certificate. And we will be emailing you with new webinars to invite you to attend the upcoming ones. Thank you so much, everybody. Thank you, Stuart. Thank you, Nigel. Thank you, Brandon. And looking forward to seeing you all in our next webinar.
Thank you, guys.
Thank you, everybody, for attending. Have a good day, everybody. Bye-bye.